Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hey everyone, welcome back to Cardiovascular Matters. As you know, this is June and it's Men's Healthcare Month. Last week, Dr. Walker discussed some of the cardiovascular issues that occur within men and ways to prevent them. And we want to take a deeper dive today and specifically speak on cholesterol-lowering medication. Dr. Walker?
Sure, Terry. Well, I think when we speak, we could speak for hours on cholesterol medicines, and perhaps we should break this down. And let's first take the most common medicine that we use for cholesterol, and that's a group of medicines we call statins. Mm-hmm. And statins have been around for a while, but what statins do is two things. They help us to create less cholesterol, less of the lipoproteins, which are what carry cholesterol around and have the potential to deposit it or remove it from our blood vessels. And they also increase our body's ability to remove cholesterol by activating what we call LDL receptors. Mm-hmm. Now, statins have been around for a long time, and early on we had weaker statins. They tended to have more interactions with other medicines, but here recently with the newer statins, we really have two very powerful statins, and those are the ones I'm going to focus on because these two newer statins, I think, are a little bit more effective, and certainly they're more used now than the other statins. Both of these are also still generic, and so these would be atorvastatin and rosuvastatin. Now, these differ a little bit from each other. Atorvastatin is lipid soluble, and because it is lipid soluble, which means it dissolves more in fats, it's metabolized predominantly by the liver, whereas rosuvastatin is water soluble, and as such, it's metabolized more by our kidneys. But both of these affect something called HMG-CoA in our body, which is necessary in making cholesterol. Mm-hmm. Now, first, let's be clear. Our bodies need some cholesterol. Our cells need cholesterol. Right. It's a very important building block. And as we started to recognize that cholesterol was hugely important, particularly LDL cholesterol, that's the lipoprotein or the detergent which carries cholesterol around. LDL cholesterol is typically the moiety which results in cholesterol getting deposited where we don't want it. It gets deposited typically in our blood vessels, and we certainly don't want it there because that causes obstruction in our blood vessels. Now, we can lower cholesterol by two ways: either make less of it or metabolize more of it to get rid of it. Well, statins affect both. Now, there's tremendous misinformation about statins. Some people are calling them poisons, and we go on and on. Well, let me first solve that myth. Okay, and it is a myth. Every medicine we take is a poison of some sort, if one wishes to use that analogy. Right. Aspirin poisons our ability to clot sometimes because it affects platelets. But I know of no one who's frightened to take an aspirin. But I have many patients who tell me, Doc, I don't want to take a statin. I've heard all these bad things about statins. Well, the biggest side effect of statins is increased life expectancy. That is very, very important. And I want to make that point again. The biggest side effect of statins is life expectancy. Now, and it's increased. However, the most common side effect is muscle aches. Right. And that is because statins are metabolized within muscle. Now, if we look at who is likely to have muscle aches when they take statins, it's typically those people who have low levels of high-density lipoprotein, or HDL. Whenever you see the report on blood fats, you usually see LDL, which is low-density lipoprotein. That's the dangerous one. And you see HDL, or high-density lipoprotein, which is the good one. That one actually is the one which, in general, is going out and picking up the cholesterol that's been deposited and gets rid of it. So ideally, we would like higher levels of HDL, lower levels of LDL. Now, that's a very simplistic explanation, but in general, what I've just said there is very true. And if we have higher levels of HDL and lower levels of LDL, we typically do better. There are some cases where there are pathological forms of HDL, but again, that's rare, and right now I'm speaking about horses, not zebras. The things more likely to occur here as we're treating patients. Now, if someone starts to develop muscle aches on statins, right, there are things we can do other than just stopping the statin. Often, if we supplement that person's medicines with enzyme CoQ10, and we see many things on TV. You see commercials about Qunol or other forms of enzyme CoQ10. Often, that can mitigate and alleviate the muscle aches that some find as they start to take statins. Another thing that I've found helpful in many patients is for them to take a tablet that combines calcium, magnesium, and zinc. Okay, again, because some of the muscle aches are calcium dependent in general. And at any drugstore, and very cheaply, one can find tablets that have the combination of calcium, magnesium, and zinc. And by using these, we can mitigate most of the muscular pains that are associated with statins. Now, there are another group of medicines, it's not a group of medicines, right now it's one medicine, bempedoic acid, which is not a statin, but it works in the same pathway. And ultimately, it affects HMG-CoA reductase A as well, just like statins do. But it does it 2 levels above at what we call the ACL pathway. Now, because bempedoic acid is not metabolized in muscles, reportedly it has 4 less reports of muscle aches with that. And it likewise can lower cholesterol. And often, if cholesterol is not controlled enough with just statins in a patient who's tolerating statins, often bempedoic can be added on top of the statins to achieve a better result in cholesterol control. Now, patients come to me all the time and say, "Doc, my cholesterol is now controlled. Can I stop the medicine?" Well, it's not curing cholesterol. It is controlling cholesterol. And it's important to stay on the medicines. Another common question that I'm asked is, "Okay, Doc, I'm on the medicine. I'm tolerating it. Yep, my cholesterol is down. Is it too low?" And that was a misconception even amongst doctors. People felt like if they saw an LDL cholesterol below what is typically called the normal range, they really start to panic and say, "Gee whiz, it may be too low. That might affect other things." Well, as best we can tell at this point, there is no such thing as too low in LDL cholesterol. In fact, there are many societies where LDL cholesterol is very low. It has a lot to do with diet and habits that they have. And what's been shown in those societies is that they don't really get nearly as much atherosclerotic disease. Okay, that clearly it appears that cholesterol is pathological in many senses. Secondly, during some of the trials with some of the newer, more powerful other types of cholesterol-lowering agents, there was a trial called Ebbinghaus, which was performed to see if we had brain dysfunction or other things, since the brain is predominantly fat, would it impair our ability to think or affect brain function? And what we found was that even with ultra low levels of LDL cholesterol, levels below 25, that there was no effect on brain function. So whereas cholesterol is needed for our bodies, we have not yet found that there's such a thing as an LDL level that is too low, at least at this point. Studies do not show that, but studies clearly show that if we bring LDL cholesterol levels down significantly, that we not only have the capability of stopping disease progression, which is really our major goal, but that there's a hint that indeed we can start to cause disease regression, which would be fantastic as we get it. But frankly, as long as we have no progression, we're well ahead of the game, because in that group of people, if we can keep them where they are at that point, then that's a major win.
Right.
And so that's really our biggest goal. The other question I'm often asked is, Doc, my calcium score was high. I've started statins. Will that make my calcium score lower? And the answer to that is no, it will not. Okay, once that calcium is deposited in the coronaries, it typically will not go away. Okay, that would be very unusual. And so I'm not so worried about the calcium in the coronaries, other than it is a marker. Now, if I have to go in and do an intervention, I worry somewhat if there's a whole lot of calcium, because calcium is the predominant mineral in bone, and it's hard. It's quite hard. And so if I have to do a balloon angioplasty or other treatment, it's a little harder to treat. But certainly, stopping the blockage in the first place is first and foremost as we treat these patients.
That's awesome. So just to understand how to determine cholesterol, it's just a simple test in the office, just a few minutes, right?
That's right. Well, the way to determine a lipid profile, which is, again, an inexpensive test,
right.
One should not have anything to eat past midnight the night before. And typically the test will give us our lipoproteins, HDL, LDL, VLDL, and it will give us triglycerides. Those are typically those basic tests that we have. And at the same time, get a C-reactive protein, because if it's elevated, lowering that is very, very important in lessening one's overall risk. But we do that. Now, really, cholesterol is not as affected if you'd eaten something that morning. But what is affected in a large way are the triglycerides. So we advise people to take in nothing past midnight, come in and do this test early in the morning. It's an easy test. It's run. It's not an expensive test. And it gives you an idea of overall risk. And keep in mind, the lower we get that LDL cholesterol, the more we reduce our risk of cardiovascular disease.
What's the correct, Dr. Walker? What's the routine for, like, somebody comes in, they have the test done, they're really high cholesterol, you start them on a statin, they're tolerating it well. When do you do a repeat test to kind of get a marker, from that baseline of improvement? And then does that also determine how much or what types of medications move forward?
Terry, that's a great question. Yeah, I typically, I tell a patient if they feel any side effects, first off to call me. But I like to check blood work typically at a month or so.
Okay.
A month to 6 weeks. If we start taking a statin, your cholesterol doesn't go down enough overnight. This is a slower process as we do it. And we often start, if someone has severe coronary disease, I often start at high levels of these cholesterol medicines. But if not, we may start the medicine and titrate it over time to see if indeed we can control cholesterol. But it does take time for these levels to go up. Another question I'm frequently asked is, won't this really affect my liver? And there are some cases where it can, in particular with the lipid-soluble statins, where liver functions may increase. And if that happens, we stop the drug. But I will also tell you that high levels of cholesterol can also adversely affect the liver function test because of fatty liver. That extra level of LDL cholesterol can deposit in the liver, creating a fatty liver. And certainly that's not good for us as well, because that can cause problems down the road. So, the number of patients who actually develop significant liver abnormalities from statins is very low, particularly if the patient is seen back and there are problems. If the statin would be stopped, then almost never would it go on to cause a significant liver problem. So I would argue that statins are a very safe class of medicines, that many patients benefit from these medicines, particularly if they have a history of heart disease, that they should be on them, and that they're safe and inexpensive in today's world.
Right.
Some of the talk around statins in the past was simply false. People say, these don't have any impact. That's not true. We now have a whole host of studies showing that statins improve life expectancy and limit the likelihood of progression of atherosclerosis. But some people simply can't take them. And some people have muscle aches, or they're a very, very small number where liver tests get worse. And the good news is we have other ways at that point that we can still lower cholesterol. It's just these other ways may require an injection that one takes every 2 weeks, or it may require a medicine that one gets an injection that might last for 6 months at a time, keeping our cholesterol controlled. It may be other types of oral medicine. So we can, in almost all patients, lower these cholesterol levels. And if we look at a sum of all the cholesterol-lowering studies that have ever been published, what we can see is the lower we bring LDL cholesterol, the better the outcome. As we get that number down closer to that zero level, we reduce things. But the numbers that we use empirically, and I suspect these numbers will continue to decline as they have in my life as a doctor, is right now, if we, for instance, have had someone have a coronary bypass surgery or a stent, or we find coronary artery disease, we want to make sure that LDL cholesterol is less than 70. And in the higher risk, less than 55. Now, in the European guidelines, in patients with multiple risk factors, that number is now 45. And that number has steadily gone down in my career as a doctor. I remember when 160 was considered okay, then 130 was considered okay,
Wow.
then 100 was the number we shot for. And so these numbers keep coming down, and those are the guidelines. But to be fair, the data suggests the lower the better. And only time will tell us that. Certainly we need to follow this more. But I think it's common sense that if we can limit LDL cholesterol, which is depositing cholesterol in our vessels, causing the blockages to occur, it makes sense that can help us. And it did not result in worse brain function. Unfortunately, as we get older, our brains don't function quite as well. But we have no link that lowering cholesterol does that. And in fact, there's some who theorize it may help to prevent that as well, as some of that's due to microvascular disease.
Right. Well, this has been, again, a very thorough look at cholesterol-lowering drugs. It is, I'm pleased to hear that these drugs are, for the most part, are generic now. They've been around for a long time. They've been studied and vetted. So they should be readily available to patients and a very economic way to make a big impact on their health. Thank you again for this wonderful, very detailed explanation of this area of medicine. Next week, we'll pick up and continue to talk about men's health. Thank you very much, Dr. Walker.
Cool. Thank you, Terry.
Thank you for joining us here at Cardiovascular Matters. So if you're a patient out there and you've tried everything else and you just can't get the weight off, look into this. I mean, he's easy to reach at www.cardio.com. Everybody have a great week, and thanks for listening.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.